Hi, I'm Mick Raich. What am I reading today? I'm reading a book called The End Game. It's a lab owner's exit strategy. I'm lucky enough to work with the author of this book, Melissa Butterworth. She helps labs around the nation find exit strategies and ways to move forward with their business and maybe gain investors and look at that the next step in their business model. So if you're interested in selling a lab or you're looking at that concept, look up this book. It's called The End Game. It's on Amazon. It's a good read. Let's talk about this week's notices and issues. First of all, United Healthcare made big news again this week, as they continue to do. United Healthcare has led the league in provider pay cuts over the last couple years, and they're continuing to do that now. The first thing we're seeing is the issue with the G0416 instead of 88305. These are prostate biopsies. There are some guidelines now, and some different payers are saying that you have to bill the G0416 instead of a 305 when you do prostate biopsies. And what we're finding is interesting is that United Healthcare is not only implementing this rule, but they're also asking for refunds from money 6 months ago from Medicare patients, Medicare Advantage patients. So if you see, if you audit your prostate biopsy cases and you see some recoupments on Medicare or Medicare Advantage patients from UHC, it might be worth give us a call. We're seeing this from other providers, and we're fighting this battle now. They can change a policy going forward, but to change a policy retroactively 6 months back, it's like a retroactive tax. That's a little bit punitive. Let's also talk about UHC in the next light. That they came out and said effective July 1st, 2020, which is a month ago or so, certain United Healthcare commercial payer members will no longer have benefits for out-of-network laboratory dialysis and durable medical equipment. United Healthcare will require the referring physicians to inform the patients that they're out-of-network if they send the work to an out-of-network lab, and that the patient will basically have to cover the cost. They're also saying that they have to basically obtain an ABN on this, saying this is going to be out-of-network, and the patient has to sign it, and the patient is then well aware that they might have to pay that fee extra. Now, United Healthcare again is trying to tighten their network. They're narrowing it down so they only lab work goes to only their labs. So if a referring physician sends it out-of-network to an out-of-network lab, they have to make the patient sign an ABN, and then they also might face some punitive damage from United Healthcare, saying they could disqualify you for their rewards program. They can decrease the fee schedule to the referring physician. They can actually hold the referring physician financially responsible for any costs that the patient may have paid in an accident, and basically terminate the agreement. So what UHC is saying here is that if you use an out-of-network lab, your patients have to sign a note for that. And if they don't do that, and the patient somehow gets billed and paid by United Healthcare, because that happens, that does happen, that the referring physician could be culpable for that payment and could be thrown out of United Healthcare's formulary because of that. So again, what they're doing is tightening down these networks. Remember, UHC is also, the third UHC thing, they're also requiring that all the laboratories that are participating have to use a test code pairing their tax identification number with UHC's separate CPT code identifier. So this happened in Blue Cross Pennsylvania years ago. They had their own CPT schedule, and what they're doing is saying this is another way for them to identify out-of-network work. So if they get a CPT code that doesn't have the UHC CPT code identifier, they'll know it's out-of-network, and they'll be able to reject that work or contact the provider and punish them for doing that. So this is for place of service 21 and 22 and 81. So that's going to happen. So again, UHC has a series of referring physicians that are trying to make sure they all use the correct labs, which they've negotiated very good deals with, and keep anything that goes outside of that, any leakage, quote unquote, to a minimum, because they've negotiated very good deals with very strong labs, national labs, at a very, very strong discounted price. And I give UHC credit here. They're continuing to tighten the belt, even though they had their best quarter ever in the second quarter of COVID. Because second quarter this year, what happened? No one went to see the doctor, but everyone still paid their premiums. So their cost, out-of-pocket cost to providers would tear way down, 50, 60% down. They had a great quarter. And what do? They come out and they say, hey, we're gonna tighten it down even more. Interesting concept, interesting company. That's all I can say is interesting. A couple other things going forward. Looking at MIPS, if you're still participating in MIPS reporting this year, and you want to be sure to consider any COVID-19 clinical trials you're doing, because if you're doing a clinical trial, this will be included as improvement activity and applies to your group. It can help you attest to this high-weighted improvement activity in one of two ways: participate in a COVID clinical trial and have that data entered into your data platform for the study, or participants in the care of COVID-19 patients may submit COVID-19 patient data to a clinical data registry for purposes of future study. Obviously, if you're a lab, you're doing this, you can submit that way. You're carved out of it in many ways. But if you're a pathology group and you have some of this and you're working with your health system on this and you're seeing COVID patients through your hospital-based lab, this is might be a good way to also note the work you've done there, maybe the studies you've done there, and submit it that way to take care of this high-weighted improvement activity. Next up, according to a recent HFMA survey, Healthcare Financial Managers Association, just 11% of health systems believe that the current levels of federal funding will be enough to cover COVID-19 costs and expenses. Of those surveyed, 89% of the executives expect their organization's revenues to be less than originally predicted for 2020. Everyone's having a bad year. All right. So what are they looking forward to going forward? They're saying, how do we handle this? How do we take care of this 11% decrease in our revenue? A lot of people laid people off in April and May, so you're going to see a corresponding decrease in cost then. A lot of our laboratories, a lot of our physician groups, both pathology, radiology, ER, a lot of them laid people off and furloughed people for a couple months. Everyone's bonus structure went down. So they're going to offset it that way. We are seeing everything ramp back up. Other than emergency practices, people are still struggling to go to the hospitals and go to the emergency rooms. We're not seeing that take place. And we are seeing some lag in some cases due to COVID testing, not being able to perform elective surgeries as quickly as we want, but they're still being performed. That's the good news. We did see a couple hospitals in late July come back and say, we're going to slow down elective surgeries, or we're going to try to hold elective surgeries. They were fearful that they would be overwhelmed with the COVID increase in actual cases. But in most cases, and in every case I know of, that really never became true. The hospitals had plenty of ICU beds. It was a precautionary measure, and everything is fine now. Everything's moving forward good. So that's a good thing. The last thing I want to talk about is the proposed pay cuts that are coming. There's a proposed 8% pay cut for pathology and I think 12% for lab. And so they can shift this money towards E&M care. So you got a big pie, and you want to take some of the pie from over here and put it over here. They want to put it towards primary care, and they're saying, hey, let's really boost primary care. Now remember, the thinking behind this was pre-COVID. So what's happened since COVID? Well, primary care, everyone went down in April, May, and they're all bouncing back up. But primary care is bouncing back up in a unique way. They're bouncing back up with telemedicine. What does this mean? Well, there's some initial startup costs for telemedicine, but the beauty of telemedicine, it lowers your overhead considerably. 90% of primary care visits can probably be done via video like this. And a lab ordered and sent out, and the patient doesn't have to come in. The patient doesn't have to get a COVID test if they need one for an elective surgery or something. None of that takes place. It's all direct virtual like this. Works out very well. What does that do? It lowers the overhead for primary care. So could we be giving primary care a big pay raise at the same time that their overall expenses as of January 21 will go down? I would argue that maybe this pay cut doesn't need to be as drastic across the board to anybody. Maybe it could be a little pay cut here and a little pay raise there. I think when you look at the EBITDA, the bottom line for primary care after they're fully integrated into telemedicine, it's going to be 20 to 30% less. Makes perfect sense. You have a doc sit in front of a video. He sees a patient. He can answer a call. He can see patients quickly. He can document quickly. And he doesn't have to pay for staff to do all the stuff that they do. Just an idea, just a concept. We're going to keep fighting that. We're going to keep you up to date on that. I'm Mick Raich. I'm the owner and CEO of Vachette Pathology and Stark Medical Auditing. I thank you for taking a few minutes to listen to me. Hope you have a great day. Give me a ring if you have any questions. Take care.